Hi, everyone. Thanks for joining today's webinar focusing on making your practice safer with aerosol management. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. If at any point during the presentation you have questions, please type them into the Q&A section of your control panel, and we will try to cover as many questions as possible at the end of the presentation. Please make sure that your volume is up and any large computer applications are closed to ensure a smooth connection. This webinar is sponsored by Schein Dental. No CE credit is being offered for viewing the on-demand version of this webinar. Our speaker today is Michelle Strange. Michelle has 19 years of experience in dentistry, is a registered dental hygienist, and is the host of the A Tale of Two Hygienists podcast. We're looking forward to your presentation, Michelle. Over to you.
Thank you so much. Hello, everyone. Thank you for spending some time with me today. I know your time is valuable, so I want to make sure I bring value to this time together. The series that I know that has been a part of this Henry Schein production has been on technology and incorporating that into your practice. And we're going to still have a discussion about that, but make a small pivot and look at aerosol management and the occupational hazards affecting all of dentistry, including orthodontics. I have a very special place in my heart for ortho because that's where I got started. This is, where my love of dentistry began. I was an ortho patient starting at 7 and ended at 24. And I wish I was joking about that, but after pretty much every ortho device ever created back then was used, I went into full braces as a teenager and then another round of ortho and orthodontic surgery in my 20s. So I have a real appreciation for complicated ortho cases like mine. I have a lot of empathy for patients that have a lot of complicated cases, and also my ortho family that I spent many, many years with. And I know that a lot of that technology, if it had existed, it would have served me very well if it had existed, but it didn't. So I was in the ortho chair quite a lot. And so my frequent visits to the ortho office, it eventually turned into a job. My first job as an adult out of high school was as an on-the-job trained ortho assistant. And this picture is actually my first practice, where we had this lovely open bay concept, and I personally had no clue about PPE and how to hold a high volume evacuator and how to properly sterilize instruments. I mean, I 100% did not know what I did not know. And once I learned it, I have been since on that quest to educate others to help keep team members safe and also our patients. And so during my time in ortho, I wasn't ever really concerned about bloodborne pathogens per se. I mean, I was young and didn't really think about much then, but bloodborne pathogens were not like super high on my list of concerns. It was, not a typical thing in ortho for me to deal with blood. We didn't give injections. We didn't perform extractions or any other bloody procedures. And that's changing for a lot of people because their practices are expanding. So you might see more bloody procedures, but it wasn't often the case. And I don't think it's, the majority of it now. And my concerns were always airborne respiratory pathogens because, well, kids, they're carriers for the common cold and the flu. And I hear more and more of the situations like, offices being shut down because of norovirus, or, something came from a school and, a few of those kids came to the practice and then it just took out an entire team. And children, they're just not great at hygiene and washing their hands and thinking about spreading their germs. And since saliva is a potentially infectious material that could create infection, ortho practices 100% need to be cautious about aerosol generating procedures, even if there is no blood present. And so we're going to go over and cover some aerosol management, including your engineering controls appropriate for ortho offices, your dental unit water lines, and then also we're going to talk about like the surfaces that are often contaminated because of spray, splatter, and aerosols, and how we can maintain that new technology if we have it in our office and prevent that cross contamination. And so I know this has always been a dry topic, infection control. Everybody's like, ugh, let's put our head down. We got to do it for our license. But now that we have COVID as a concern, I feel like there's a lot of people like perking their ears up just a little bit, and listening to this a little bit more. And so let's get into it. Let's get in and get ready for that info. So I just want to quickly review some terms, and this may seem elementary, but just for continuity in this presentation, I just want to review them because I also believe reviews are never a bad thing. So the CDC reminds us, depending on the dental procedure performed, aerosols from many of our dental instruments have the potential to contain droplets of water and saliva, blood, and other potentially infectious material. And this falls true in orthodontics. In fact, ortho sees a lot of respiratory concerns amongst clinicians because of even silica production during debonding. And so our dental aerosols and concerns are not only due to infectious material, but also from chemicals. And dental aerosols and splatter, they travel through the air and they settle on treatment area, environment surfaces, and equipment, also the patient, the dental professional, and often on the floor. And the spatter can the splatter can commonly be seen on, the face shields that we wear, any of our protective eyewear. You can see it on the patient's bib. So you can see it everywhere. And a lot of times it dries clear and isn't easily detectable. I always found it so funny that we only change certain things when visibly soiled. And I'm like, but saliva's clear, it dries clear. Like, why is that a thing? So I think we might see some changes come from that because saliva is a potentially infectious material that dries clear and we can't see it. So we might need to change things more frequently. And spatter and splatter sometimes feel like semantics and are sometimes also used interchangeably. I've asked so many people, like, what's your definition? Like, if they're in the field of forensics or even aerosol, like they create oh, what's the word? Like your chemical, like your aerosol cans and stuff. I've even asked them, like, how do you define aerosols? And no one has the same definition. It's all over the place, unfortunately. But what I can understand is that they spatter and splatter are both over 50 microns because we can see it with our naked eye. And the CDC has advised caution when performing these aerosol generating procedures, in particular, procedures that are likely to induce coughing or anything that we're going to create that aerosol. And so, in an ortho office, bracket related treatment obviously is going to be more likely to generate body fluid exposure than a liner treatment, which, I mean, that seems very obvious. And when aerosol generating procedures are performed, proper respiratory protection is required. And we're looking at least a level 3 mask. And currently, a lot of people are being required to wear those N95s. And the reality is, most orthodontic offices, they have this open bay, and that really limits the physical barriers and the feasibility to separate patients. And in my practice, we had these beautiful floor to ceiling windows in front of like these 4 chairs, and they provided a ton of natural light. But it also got super hot in the summer, and we had a fan that we turn on when in the afternoon. And this is also something that we have to be careful about when we're doing aerosol generated procedures. It is not advised. It has never been advised, especially during times of COVID. And aerosols, they're different, of course, than our spatter spray and droplets, and they can't be seen with the naked eye. The spray that we create with our devices contain usually an aerosol and a droplet of some sort, because those aerosols, they take considerable energy to generate, and they are going to consist of less particle sizes, usually less than 10, that are not visible to our naked eye. And they can remain airborne, as we have all learned with COVID, for quite a long time. So they definitely should not be confused with those large particles of spatter and spray. And we break those aerosols up into categories. And in ortho, this does look a bit different compared to our other general dental practices or specialty practices. But you will do things like high speed and slow speed hand pieces in ortho. So that still puts you in that high aerosol concern. And you're not typically taking intraoral radiographs, but you might do intraoral scanning or even photos. So pre and post intraoral photos. And that actually goes into that moderate risk of aerosol concerns because it could induce a cough and possibly a gag reflex, which could then spread infectious respiratory material from, the patient to, the surfaces and us as well. Now, procedures like cone beam scans and extraoral radiographs, for obvious reasons, those are in the lower category. So those would be very good procedures to get out of the way right now. If we are in that slow, some of us are not even, I'm not even seeing patients until probably mid-June and into July. But if you're getting that slow open, these would be reasonable procedures because they are very low on the aerosol production. And I did check out the American Association of Orthodontics website for the recommendations during COVID closure, and they were concerned about aerosols as well and recommended reducing them as much as possible, which that's what we're all trying to do. And it was suggested to reduce the number of patients and types of procedures during the shutdown. But those patients are going to want their brackets off soon. I know I wanted them off as soon as possible. So how do we manage those aerosols when that time comes? And again, if you're doing these soft opens or you're still shut down, depending on what area you are in, this is going to probably look very different for each person, but there are some very specific things that we all can be doing that, doesn't matter where we are physically. And I did want to share with you this 2008 study, and because it looked at inhalation of aerosols during fixed ortho removal. And it stated what I feel is obvious, that during enamel cleanup after removal of those fixed appliances, aerosols and splatter and dust are produced and they can be inhaled. They do mention that it's a lot of those inhaled particles are harmless and some might be associated with chronic diseases, but they also might be associated with acute respiratory diseases. And aerosol particulates produced during that enamel cleanup were inhaled irrespective of the handpiece, if it was high speed or slow speed, or if there was presence or absence of water. So they were still inhaled. It did not matter what you used. And they concluded in this study that we can indeed inhale those particulates. And if we don't have the proper engineering controls that I'll talk about, or PPE, some of those particles are going to be deposited into the terminal alveoli of the lungs and only cleared after weeks or months. So they can sit in there for weeks or months. And those particulates came from enamel and the bonding adhesive, cement, and even some of the water from that handpiece. And water from the handpiece, we'll talk about that as well, because that is a huge concern if we aren't testing that water and treating it on a routine basis. And now the EPA and other health organizations, they categorize those particulate matters by size because different size particles have different health effects. And particulate matter, or PM, is a name given to that complex bunch of microscopic pollutants. So you have PM of 10 that's really coarse. You have PM of 2.5 that's very fine. And they include all kinds of stuff, pollution and dust and pollen, pet dander, which is probably what I'm breathing in right now. And also viruses, bacteria, mold spores. And the nose is amazing. The nose is great because it's going to typically filter out air particles above 10 microns. But if those particles are less than 10 microns, which are things that we can, generate with our hand pieces and things like that, it can enter the respiratory system. And if it's less than 2.5, again, enter that deep alveoli. And then although most inhaled particles, as I mentioned, are harmless, some might be associated with acute and chronic respiratory diseases. And these respiratory diseases or infections are highly communicable in a lot of cases and have been linked to some of the microbial inhabitants from the oral cavity. And so, yes, we need to worry about COVID and what life will look like once we return, but we should also be concerned about other respiratory issues, the flu and the common illnesses like the common cold and other coronaviruses. We don't have a lot of contact tracing happening in our dental industry, and we aren't tracking every time someone gets the flu to see where they could have contracted that. I know in my practice, we don't typically call the patient 2 to 3 days after an appointment to make sure they are healthy still and that they haven't contracted something from us. I wish we had more occupational data in dentistry, but we just don't. But these common colds and flus, How many of you have had it just take out an entire office, like your whole team? Somebody comes in with the flu, it could be a patient or it could be a sick kid, it could be one of the team members, and you just pass that around forever. I mean, we've even had a cough that just lingered for months and months because I'd get rid of it and somebody else would get it and then someone else would get it and then I'd get it again. And it was just this whole mess. So respiratory illnesses are a really big deal. They might not kill us, but they definitely create a lot of havoc in our life. And in this 2011 study, this set of authors stated that there is a very little that is actually known about the quantity and quality of the airborne microbes in the dental practices. And so it's hard to say, what we're getting and what we're contracting via our patients or these chemicals and debris that we throw into the air. And in 2017, this article reviewed bioaerosols, and it brought up a point that I've wondered about for years when I've been, tackling aerosol research for like the last few years. Most of these studies in dental practices, they only focus on bacteria and they don't really focus on the viruses that are generated during our aerosol procedures. And so we're dealing with almost invisible aerosols, and it has always and will continue to be important to minimize or eliminate as much as possible during our clinical situation. And I mentioned earlier that not all that spatter and spray is infectious. It could be chemical as well, which has its own concerns. If spatter were to contain etchant and that landed on the patient's face or the eye or the clinician, that's a concern. If we do create aerosols or spatter with infectious material that then create the respiratory infections, that's a problem, especially now that we have seen a gap in vaccinations. You are hearing about measles outbreaks in certain areas. I believe for offices that do see children routinely, COVID isn't the only virus that can wreak havoc. But again, something like measles and the norovirus and just the common flu can really get us very ill and cause some issues. But dentistry has amazing fail-safes in place called standard precautions. If we practice these, including in ortho practices, because that is a part of, we are in ortho, everything, it's all under that umbrella. We can practice these and keep ourselves and our team and our patients safe from cross-contamination. Universal precautions, that has evolved into standard precautions. I keep reading that on a lot of these social media forums that everybody's like, we practice universal precautions. I'm like, let's just also all agree that we're going to update that term. It's going to be standard precaution. So it just evolved from universal precaution. So universal precaution, of course, is going to mean that we treat everyone as if they're infectious, including our orthodontic patients. So it doesn't matter what we think, they're all infectious. But then standard precautions takes that idea and takes it a step farther and says, you also need to be using or doing proper hand hygiene, that you need to be wearing that PPE. That's going to keep you safe. You need to have good respiratory hygiene and cough etiquette, and also a respiratory program within your practice. That we're going to sterilize our instruments, and that we're going to do good, safe, sharp safety engineering work practices, that we're going to clean and disinfect that surface. So when a patient presents with, just as normal, if we use all of those things, we are very well taken care of. We are. But if they do present with an infection or possible signs and symptoms of an issue, then standard precautions alone might not be adequate to prevent that transmission. And in this situation, you'll supplement your standard precautions with transmission-based precautions, because that's going to be your second tier of infection control. And that's going to include, your transmit controls that prevent or protect you from contact and droplet or airborne viruses and bacteria, and making sure you stay safe with that second tier and on top of standard precautions. So I just want everyone to start using that terminology versus the universal precautions that we've known for many years, but that it has evolved. And in dentistry, we follow the guidelines set by CDC, and we also have OSHA guidelines to help prevent cross contamination between patients and to protect us and our team from harm and infection. And when I ask my colleagues in ortho practices, they're not as familiar with the CDC guidelines, and they do not all have a designated infection control coordinator. And in 2016, that update from the CDC, they did recommend that every practice have a designated infection control coordinator to help implement good practices and follow through with the recommendations that they are giving. And you can all go to cdc.gov/oral health and find all of that information laid out for you. And so we have had established controls to reduce our risk of exposure and our aerosols. I mean, we have for years. And you can see some of the controls here. They're in the OSHA and CDC. Some are discussed with NIOSH and CDC. There's a lot of cross-pollination, a lot of crossover between the two. In fact, today I was on a call and someone was like, yeah, I almost reported them to OSHA for that. And I was like, that's actually not OSHA, that's CDC, because that's patient safety. But they both have these hierarchy of controls that keep us and the patient safe. And the hierarchy of controls has been used as a means to determine how to implement these controls effectively and feasibly. And the hierarchy ranks controls depending on how reliable they are and how effective they are. And you'll see that it includes engineering controls and also our PPE. And then at the bottom with OSHA and CDC, they talk about environmental infection control. And so let's talk about some of those engineering controls, because that's what's going to help reduce those aerosols and the droplets in the dental setting. I love PPE. PPE is great. I'll talk a little bit about that, but that is the least effective barrier in a lot of cases. It's about using these engineering controls, and engineering controls are just safer devices or equipment that were designed to create a barrier between the healthcare worker and the exposure of the risk. So Sharps container, like that's an easy one. That's such a great example of an engineering control. And they are required to be in ortho practices for like your ortho wires and brackets. But another one is our high volume evacuation. And the thing about high volume evac is that training is a must. It's a must for a lot of these engineering controls to make sure that we are all trained to competence or competency. And if you haven't used it in the past, these high volume evacuations, it is cumbersome. It's rough, y'all. Another, when I was an ortho assistant, we only used high volume evacuation if the patient had that inflamed puffy tissue. And so when my doc was taking off the glue and doing the debonding, if they were starting to see a bloody spatter, then we broke out that high volume evacuation. But that's actually the wrong way to do it. We should be using that high volume evacuation every single time that we're doing our debondings and anything that's going to create that aerosol, even rinsing away the etchant. And we need to be trained again to competency on these items so that we can use them efficiently, especially during a crisis, because we want to reduce that risk of a serious disease. But this is a great time to slow down and make sure that entire team is trained. If that high volume evacuation isn't a typical device that your assistant has been using, it's gonna, like I said, it's cumbersome. It's like ergonomically not nice. It makes your wrist tired. The tubing is bulky. Sometimes if you haven't been using it, you pull that tubing out and it's like cracked. So we really need to take a step back and look at, can we use it, and do we use it enough that it's actually maintained properly? And so I've also found that with our engineering controls like high volume evacuation, that it's not a one size fits all kind of thing. There's so many options out there, and your choice, or you could get to choose which one you want to use. And it's going to be very personal for you, because it's going to depend on your practice. It's going to depend on the procedures you're performing in your practice. It's going to depend on your team and what works for them, and if your patients can tolerate that device. Also, it's going to depend on your vacuums and if they can tolerate, the high volume evacuations. If you have these older ones that haven't been run, haven't been maintained, and you go using all the high volumes in each unit, your vacuums are not going to be really happy with that. So it's going to be a very personal decision, depending on what you choose for your practice. And so you may choose something like an extra oral suction. Extra oral suctions have been around for a while now, but they're starting to gain that popularity right now. I personally would love this as my, little robot assistant to help me during my hygiene appointments. It's hard to deal with the pooling of the water and the aerosols, and something like this can be set close to that patient's mouth to capture the droplets and the aerosols being produced. There are a few companies and versions of this. So again, it's just going to depend on your practice and your needs. And you can find something that fits well if you find that extra oral suctions would be great for you, and let's say for debondings, because sometimes assistants do have to get up and walk away, right? Maybe they got to get the next patient. Maybe the autoclave is dinging and you got to turn it off, or maybe you need a different instrument or a different burn, so they get up and walk away. And sometimes we don't stop those aerosol producing procedures. That's where an extra oral suction would be really nice, just to be sitting close to the face and be constantly removing those droplets and aerosols. And we've had handheld intraoral suctions. We're all aware of these, I'm sure. But what I didn't realize was how many varieties of evacuation tips were out there. The typical plastic pieces, the ones that you'll see, in that screen, the long ones, they have different openings, different sizes. Some are round, some are square. Some even have mirrors and lighting, and also lighter HVE tubing. Because again, if wielding that HVE tube is too much for the wrist, there are lighter tubings to help your dental team. So it's also important to note not all of these work the same. Some will be better at the pooled water in the back of the throat. Some may be better with your particular vacuum unit, just depending on how strong it is. And some will be better for certain clinicians and certain patients and certain procedures. I personally have not found the holy grail of high volume evacuation. I have a few that I tend to jump back and forth with, just depending on my procedure and what I need. Often I will use two of this at the same time, but I produce a lot of aerosols in my procedures. A lot of it's to help me with the pooling in the mouth, but also the aerosols produced in the anterior. And, if you're not working with four-handed dentistry, just know that it's not a one-size-fits-all game, and that you're just going to have to play like Goldilocks and find that right one that's going to fit you, again, the clinician, your team, and your particular practice and the procedures that you're performing. There's also a variety of low volume evacuations out there, but these were never meant to reduce aerosols. I've used this primarily for most of my career, and I was constantly sick and also covered in God knows what most of the time. They were never meant to reduce aerosols. This is for pooling of water and will not catch those droplets and aerosols that we produce. And I would be remiss to not bring up the concerns of using your low volume evacuator at the same time as your high volume evacuation. So, when you turn both on, you hear that suction like decrease in that low volume evacuation. And that will be a concern because of backflow. So many years ago, the CDC addressed backflow. So backflow is when those previously suctioned fluids in that dental tube flow back into the patient's mouth. It occurs when that suction tubing is sometimes elevated. So let's say I'm bringing it over and trying to assist and put it down into the patient's mouth. That flow from the tubing can go right back there. And if you see on the screen here, that person's closing their lips around it, that is no longer recommended, especially if you do not have a backflow. And in fact, they say every 1 in 4 patients will suck back the fluid that's been sitting down. And when you dock your high volume and it sits in that little scoopy part of the tube, 1 out of 4 people, which makes me want to vomit. It's so gross to think about that, but there's an answer for this issue. It's called a backflow preventer or a valve, and there's quite a few out there. There's some that will replace your silver valve, and then there's some that you would just use as you need it, and it would go on top of the valve, and you can see both options there in the screen. But I would highly encourage you, if you're going to run low volume and high volume, and if you have a patient or if your patient population, which I trained all of mine to close their lips years ago, and now they are kind of, it's in their brain. I got to close my lips to get all that stuff out. I can't even get the suction out of the mouth fast enough before they're closing their lips. And there's potential that they'll get the fluid from the previous patient. So I always have a backflow on mine. Also, if you are using your high volume evacuation to control aerosols in the practice, we want to make sure that we take care of that very expensive vacuum system and it's functioning at full capacity. So in addition to preventing cross-contamination with your backflow, you got to maintain your evacuation systems. You're going to have these chemicals that you can run through. It is a end-of-day process most of the time. You can also test your vacuums and make sure that they are running efficiently. According to Rella Christensen, you can use a 1 liter bottle, fill it with water, and then put your high volume evacuation in that bottle, and it should suck it out within 8 seconds. That's how you know that you have a functioning vacuum system. But it also would be great to have your technician come out there and take a look and evaluate your stuff. But this is just a great time to look at that. And as we are slowly getting back to business, depending on what state you're in, let's use this time that we are, usually we're eyeball deep in patient care. So let's take this time now to confirm that we have all of our equipment working and that everybody's trained on how to manage that equipment and use the high volume evacuation. So patient protection, protection, I should say, it's not just for us. We want it for our patients too. We want to make sure that their eyes are always protected, and you may want to think about their nasal passages as well, especially when you're throwing all that ortho glue coming off and they're just kind of breathing it in. Now, if you're using high volume evacuation properly and your assistant's like really on top of that, it's not as huge of a concern, but this is a possible option, especially for immune compromised patients. Eyewear is a must for patients and for clinicians. I personally have had a piece of acrylic fly into my eye while I was delivering a retainer. I'd like to say that only happened once, but I did not learn my lesson, and I've had to use the eye wash station multiple times. Now I feel naked without my eyewear, but this can happen with patients as well. I mean, who hasn't clipped an ortho wire and it just kind of went flying out of the mouth? And it happens so much that it could possibly fly into their eye. And also, if you are again removing and rinsing off that etchant, if you hit the high air water syringe just at the right angle of the tooth, it could fly out. So the patient at all times needs to be having eyewear, and as we do as well. So indoor air quality contamination, it's been evident for years. Many industries and companies have begun installing these air purifying systems and HEPA filters. Unfortunately, most dental offices have not yet taken that proactive step. I think a lot of it's due to lack of awareness. It's also a costly thing. So we definitely we're like, oh, it's fine, we'll do it later. But now we're seeing more of that. The people are talking about this now. And so I mentioned earlier that not all of that we're not only exposed to, infectious things, but also chemical hazards. And the chemicals in our practices, they are hazardous. And so in the dental office environment, the most practical and convenient solution is to have these like standalone air filter systems, which clean by constantly drawing that polluted indoor air out and exhausting this clean filtered air into the room. But you got to think about some things when you're looking at your air purification systems. How much does it cost? What's the airflow capacity? Is it good enough for your open bay if you have that open bay big room, or is it going to be good enough for just your small room? What are the filtration capabilities? Is it super noisy? Because that would obviously not be a good thing to have in the practice. And so if this is a route that you would like to consider, be sure to know how many air exchanges occur per hour and then the specifications for filtration. Sometimes they will say they filter large microns at whatever percent, and that's great, but that means that it might not be great at handling small particles like bacteria and viruses. Or they'll be really great at the small particles, but they're not really great at the large ones. So you just got to find that unit that fits your needs. And also for example, this particular unit has 6 air changes per hour. And so that's going to be the recommended exchange. I see it all the way from 4 to 12, but I am seeing 6 more in literature. So I did want to talk about dental unit water lines because they are a big concern right now, especially after the incidences in Georgia and California. And this was postponed because of COVID, but we are about to see a very large settlement going to these families, and it's going to be one of the bigger ones that dentistry has seen. And so our dirty dental water lines, they're such a source of potential infection that could be a respiratory concern. And in fact, many dental professionals have antibodies present for Legionella. And because we're exposed to those aerosols constantly, sometimes we might have been sick and we just don't know why. And it could be because we were just generating biofilm and bacteria and God knows what from these water lines, and we're breathing it in. And so biofilm management, we talk about that constantly in dentistry, but it's not only for the mouth. It's not only for home care. We have to manage that biofilm in the water lines that we use. And so maintaining your dental unit water lines, it's going to be included in your operatory reprocessing for every dental specialty, everyone. You should be running your lines for 2 minutes at the beginning of the day and then for 30 seconds between patients, in addition to doing some water line testing and shocking. And even if you didn't use water on that patient that just left your chair, you still need to run that line, because if the next patient uses water, or you need to use water on that patient, that it's been sitting in that line for X amount of however long. And it does not take very long for that stagnant water line to produce biofilm. And so the moment you open up that line, they get that pressurized version of all that biofilm right into their mouth. And so there are some awesome companies out there that will help you better understand this process and make it a little bit more efficient, because I promise you all these things are not designed to actually make you work harder. And I know reprocessing in ortho is super fast, but it is making sure that you aren't getting sick, your team's not getting sick, and your patients aren't getting sick. So this is actually me. Let me make sure I can click it. There we go. Testing my water lines during this shutdown. I went into my office. I have 4 rooms. I do this quarterly, but in the very beginning, I did it monthly because I failed a lot of my tests. I had dirty dental water lines. So I had to shock my lines routinely and until I started passing them on a routine basis. This one is called a quick pass. It gives you results in usually 48 to 72 hours. It's very easy to implement into your routine equipment maintenance protocols, and will give you some, like I said, quick information about the quality of your dental unit water lines. And we want to have our dental unit water lines that meet the recommended drinking water of 500 colony forming units. And that particular dental lab, I had an interview with them the other day, and they're like, we have easily seen 200,000 in a lab test. And I'm like, oh my gosh, that's a big deal. So we want it to be at least safe drinking water of 500 CFUs. So I talked about those high volume evacuation because those are about our engineering, or those that go into that engineering control. Also, our administrative controls are super important, but I did want to just touch briefly on PPE. I know there's webinars all day, every day that you could go and listen to and learn more about PPE. There's also a lot of information on the CDC website. But I did just want to touch on the fact that ortho is 100% included in those guidelines and recommendations for wearing PPE. You're probably seeing this a lot just with COVID right now. If your patients are not used to seeing you like this, and your team all garbed up, it would be great to communicate this beforehand. I would think once we are back to that conventional capacity, according to the CDC, that a mask and a face shield would just always be the best, option for ortho, because then you don't have things flying into your face, and they're easy to put on, and the child or the person in the chair can still at least see your eyes and have that connection with you. And there are plenty of face shields designed so that your team member wears. So if they wear prescription eyewear, there's some that will just clip onto those glasses. So there's a lot of options, and it's just going to be dependent upon your team. And but you are included in that PPE guidance from the CDC and for OSHA. So, as I was in ortho, and I did not wear most of my PPE. I never wore long sleeves. I barely wore a mask. I definitely didn't wear eyewear. I wore gloves, and that's about where it ended for me for a really long time. And then had to get serious about it. And if you're not used to doing that, you do have to train up on it, because it's not as easy donning and doffing those things as you might think. And so I mentioned that we also have to properly clean our surfaces. If we miss any droplets or aerosols that without, maybe our high volume evacuation, we missed it during that moment, and they land on our equipment, we have to clean and disinfect. This was always an issue for me in ortho because of how fast we're turning over those chairs to get that next patient back. It's, however, a requirement that we follow the instructions for use on the disinfectant. And if that says a 2-step process, then you must first clean and then disinfect. And then we have to give both of those steps the time for that disinfectant to sit on that equipment so it actually disinfects. There are 1-step products with about a 1 to 2 minute kill time, which I think would be ideal for ortho practices. But I would encourage you to check to make sure your equipment's compatible with that. Some of these products are harsh and they will tear up your technology and your equipment. So we want to perform proper environmental infection control, but we don't want to ruin our expensive items that you've bought for your practice. So this is something, again, that infection control coordinator that the CDC recommends that you have, they can figure these things out for you. So if you find your kill times if you go looking at your chemical that you have in your practice and it says 5 minutes, I don't know many ortho practice. I don't know many people that have a whole 5 minutes to wait for that chemical to stay wet. And then you start your barrier wraps after that. So you want to find something that's going to work with your clinicians, your employee compatibility, your equipment compatibility, and also gets you to turn over that equipment safely and efficiently. You can look, this is also a concern that I keep hearing, will it kill coronavirus? Really, even in ortho, the recommendation is always to have an EPA hospital disinfectant or tuberculocidal claim. If you have that tuberculocidal claim, it's probably going to kill a coronavirus. But this is really important that we go and we make sure that we know our disinfectant and that we know the claims so that we are, again, making sure it's compatible with our equipment, but it's also killing the things that we want it to do. Because it will even also say on there norovirus and influenza and things like that, because again, kids, gross, they have things and they can make us super sick. So we don't want to give it to the next kid that sits in their chair or adult, because we see everybody now. Now, if you are pre-soaking your disinfectant, this is a no-no. I don't know why that just did that, but this is a no-no. We do not suggest that anymore. Both the Centers for Disease Control and Prevention and the Organization for Asepsis and Prevention, they do not recommend pre-soaking gauze and disinfectants. That cotton fiber can inactivate the disinfectants. So OSAP says if you're going to use gauze with a disinfectant to wipe things down, you can saturate it with the disinfectant at that time of use. So it's about the instructions for use. And I get pushed back on this. I mean, pretty much every time I talk about environmental infection control, and people want studies. And I'm like, I mean, the CDC does have studies. You can actually go to that website at the bottom of the screen. But the reality is, I don't have to give you studies because it's not in the instructions for use. And the instructions for use are law, especially when we're looking at the EPA. EPA does not play around with their instructions for use, and they want you to use it exactly how it is recommended. So don't soak your gauze. Make sure that you know how to use it, and if it's for cleaning and for disinfectant, and if it's for one time or like a one step or a two step process, so that we can manage any aerosols that escape our high volume evacuation. But we also want to manage our technology. We just learned, how amazing technology is. You've been listening to it. We're hearing more about teledentistry as well. But that doesn't stop with just, our cone beams and our intraoral scanners. That's our curing lights and our keyboards and our mice, our mouse and our screens. It's all of that stuff. So I think this is a great time to implement technology, but it's, we got to learn how to manage it properly. So think about how you're going to cover it. How are you going to clean it? How are you going to disinfect it? Know if you can use certain disinfectants on it. And if not, what can you do to prevent that cross-contamination? And I know some of these items are not always in that line of fire during aerosol production, but sneezing, coughing, and dirty hands, they are ways to create cross-contamination between patients when using these items. So I cannot emphasize enough how important it will be to know the instructions for use for each piece of technology and what it recommends for the protocols to wipe it down. Does it say that you should be using a barrier wrap? Does it say that you can wipe down that hospital grade with a hospital grade disinfectant, like I mentioned, that tuberculocidal? What does the manufacturer actually recommend? And then we make sure that the team understands this, because someone could see there, is a deal on disinfectants, the wipes, and they want to buy it to save you guys some money. But it might not be compatible with your equipment. So now the dollars that you saved on that disinfectant is going to cost you in parts on your new equipment. So just make sure the entire team understands the proper protocols for disinfecting and managing your technology, and what's going to happen if somebody coughs and sneezes while they walk into your, CBCT. What's the protocol for that? And just define it. So I was in an office that had two types of scanners, and their instructions for use were different as far as cleaning them. So be aware of this, because one may say barrier wrap and so you barrier wrap it, but then the other one's like, don't think for a moment you can touch this with a cleaner. And then one might be like, yeah, that's no problem. Wipe the whole thing down. We got this thing covered. So you need to know your instructions for use, and also remember what you're touching with these things, with clean hands versus gloved hands. So the keyboards of these units are just a breeding ground for pathogens. If you or your team are touching the keyboard while using this device, you're going to need to use a barrier wrap or a keyboard that can be wiped down properly. If these scanners sit in the room or in the area where those aerosols are produced, just be mindful of that. And maybe it needs to be covered or put in a different area and pulled out when you need it. And so barrier wraps, they're a great way to prevent cross-contamination of your technology and your equipment, and to reduce the amount of chemicals that you have to use on your environmental surfaces. So they're not just for the cone beams, they're not just for intraoral scanners, but again, they can be for your curing lights and your keyboard and your mouse, or any time that you feel like you're taking a lot of time to really clean that item, barrier wrap it. That's a great thing to do. So covers, they have to be fluid resistant. They need to be approved by the FDA, and they need to come in a variety of sizes and shapes to make sure that they fit your equipment properly. And I know that this might not feel as aesthetically pleasing, and my little hippie heart hurts to see all this plastic. But if there are areas like my tray cover or my air water syringe that I'm always struggling with, or the flip up of your high volume, we barrier wrap that, because they're very difficult to manage into all those nooks and crannies. So define what's going to get barrier wrapped, define what's going to get cleaned, and then make sure the team is trained on all of that. And again, if you do have any questions about anything I said, or you're like, what is this infection control coordinator she was talking about? You can find all of this information at the cdc.gov/oral health. And there's plenty of resources, but I would highly encourage finding that team member that is going to be able to say, hey, y'all, I think we're making a lot of aerosols with this. Let's try this high volume evacuation. Or looks at another team member, is like, I see you're struggling managing and keeping on top of the doctor without hurting your wrist. What what can we do? And you designate that person so that they hold everybody accountable, but they also bring consistency and continuity to the infection prevention strategies of your particular practice. So I just wanted just to say and remind, these recommendations, they're designed to prevent and reduce the potential of disease transmission from patient to patient, from healthcare provider to another healthcare provider, and from healthcare provider to patient. It's getting everybody, it's keeping everybody safe. So oral healthcare practitioners, we have that ethical responsibility to provide that evidence-based and safe treatment for their patients. And the magnitude of disease transmission from dental procedures and its influence on healthcare associated infections, it's really not fully known. However, compliance with the established infection control guidance that we just saw from the CDC, that is a part of our ethical conduct as dental providers. And so I really thank you for your time today. Again, I know it's super valuable. I hope I brought some pearls and some info to you and gave you some guidance. And I would love to open it up now to some questions. I think I kept seeing it pop up there. So I'm thinking you have some questions for me.
Yes, we have so many questions, so
Oh,
let's get
okay.
right to it.
Oh,
Let's
wait, let me
see.
give that back.
There is fluorescent UVC lighting to hang on the ceiling of sterilization rooms. Do you know how long that lighting can last?
I wonder if they mean the light bulbs or how long it takes to sterilize the area. Honestly, it's going to go back to instructions for use. And I don't mean to say that to be like a cop out, like I don't know the answer, but it is incredibly hard to keep track of all the things that are out there for technology and infection prevention. So just read what those instructions say. And honestly, product evaluation is huge in infection control. I know you guys do that when you think about the next, clear aligner therapy you bring in, and the brackets that you choose to use. But it definitely falls true for our equipment that we use for infection prevention, because some of them don't have a lot of great claims. And I think we're also about to see a lot of companies that come up with amazing products that seem really great, but they don't have the research and the data to back it up. So we really just got to go for those instructions for use and use the CDC, use FDA and OSAP as a guide on those things.
We did get a couple questions regarding hand pieces.
Mm-hmm.
What about electrical surgical drills as opposed to high-speed hand pieces?
They still produce some kind of spatter and spray. So even your air water syringes are creating spatter and spray, and so are your slow speed. So if you do like pumice the tooth to prep it for, your bonding, that's going to create a spatter of some sort. So it is recommended to use your high volume evacuation with all of those procedures.
Let's see. Do we have any evidence-based literature that shows the rates of spread in infectious diseases in an ortho office, COVID or non-COVID?
No, no, no. And, quite honestly, it's a thing I've complained about for years. My history has been looking at aerosols for the last 4 years or so and diving into these studies. And there's been nothing. And I still refer back to a lot of the things that from 2004 and even 1997 that hasn't been updated. And I've just been like, can we do something about this? But now we have a reason. And now I think we are going to see a lot more data come out. But there's not much. Like I said, in that one study, they bring up that it looks at bacteria and not viruses. So we don't even have a solid understanding of all the things that we create, because we've looked at bloodborne pathogens for years, and there is an airborne standard that we should know about, but we've been so focused on the bloodborne pathogen that we really haven't looked at aerosols.
And then what's your take about having plants in the operatories? This person didn't find anything in OSHA or the CDC guidelines.
Yeah, that's actually a first question. That's a first for me as well. Can you wipe them down? I mean, sometimes there's those waxy leaves, and can you wipe them down with soapy water? Because I would categorize that as a housekeeping surface. That's not a clinical contact surface. So when you have environmental infection control, you have clinical and housekeeping. So housekeeping will be like your window seals and your floor and the tops of cabinets. Those things can get wiped down once or twice a week, as long as they're not getting a lot of, soil for some reason. I would probably put houseplants in that category. And if you can wipe the leaves with like warm soapy water or spray them down. Honestly, I don't have any research on that. So that is just my anecdotal opinion. So take that with a grain of salt. But for me, that falls in the housekeeping category.
Thought that'd be a fun one for you to answer.
Yeah, thank you. I'm going to put that on my list of things I'll go research now.
And then for those of you asking, this presentation is being recorded, so you will receive the link to the recording next week via email. Let's see. Do you recommend extraoral suctioning if you always use HVE with an assistant during the debonding? And then also, is there less aerosol in debond without water?
So that one study said there was slightly less aerosol, but it still produced enough for it to be captured on within their media that they had placed around. Yeah, water would have a little bit less. And then you add that extra element of what's in your dental unit water line when you add it to the debonding. What was the first part of the question? Oh, if you can use extra oral. I'll tell you, if you have a real good rhythm with your assistant and they are, they have a nice, beautiful technique with their high volume evacuation and they're really staying on top of it. There is no science right now to say that you would need that. It just makes sense to me that if, again, you have that rhythm and there's no stopping and starting and like I pull away, but you're still removing the bonding and I come back, as long as there's none of that, I think you could adequately remove the spatter spray and aerosols and debris from the air with your high volume evacuation.
You suggest that a hygienist have an assistant with them while performing a prophylaxis.
I mean, wouldn't I? I mean, what a dream that would be. I think right now it would be ideal. I do know that that's an extra cost. Unless you have a spare person, it is one of the recommendations to have somebody doing four-handed dentistry with you. But also, I have not ever had an assistant, and I have a lot of these high volume evacuations in my practice that I've been trained to competency on. So I feel comfortable. I'm not producing aerosols anytime soon. We're not even seeing patients anytime soon. But when we get to that point, I do feel confident that I will be able to manage that. If your team member has not been trained on high volume evacuation, I think they do need a little help. I think it would just, man, that would just be so great from your risk, great for the patient, really showing that effort as well. But I know that not everybody can afford that cost right now either.
How frequently do the isolation gowns need to be replaced in the dental practice for non-surgical procedures? And in addition to that, do we have to change masks for each patient, or can we use them for multiple patients?
I'm wondering if they're talking about right now in this moment or just traditionally, because traditionally, and when we're pre-COVID and our conventional capacity, according to the CDC, masks are considered medical devices. So they have always been recommended to be changed every single patient and no longer for 60 minutes, most of them. But you do have to go back to that instructions for use, what they say. And because they're considered FDA medical devices, their instructions are regulated. Like that is a law that you need to follow. Like there's no ifs, ands, or buts about that. So if you were thinking about it beforehand, yes. Now, of course, we're in this contingency capacity where it's a fluid change day in, day out. So they are recommending the N95s that can be worn all day long with a mask on top of it to prevent soiling of that N95, because it is still recommended that if you get a soiled N95 that has to be disposed of, that you can't. I mean, there are some disinfecting, and again, CDC has a whole guidance on that, disinfecting those N95s, but Then after this, when we move out of contingency capacity and more into conventional mode, yeah, you will always be required to, I suspect always, to change that mask. And then your gowns have always been following that if visibly soiled. So it did not need to be changed in between patients. Now it is recommended that you change it between patients while we're in this crisis and contingency capacity. Again, I just have never really understood the visibly soiled thing. I mean, if I'm just throwing aerosols, even if I'm just doing my slow speed, I might not see the blood, but I might have God knows what else on my, the front part of my jacket, and my loops just hang on top of it. And I've just never understood that. But you can do laundered services. You can use your cloth jackets if you have enough to rotate through for each patient. And which again, it poses a problem for ortho, because you're just like in, and next patient, next patient, next patient. I know that's not a real great, because I'm not really sure what you're talking about as far as time wise, but you should be always following the CDC guidelines. So I think that's a real clear cut answer, is as long as the CDC is saying it, that's what you should be following.
What is the safety precaution regarding aerosols coming from ultrasonic cleaning of instruments?
So that's super important, to close the lid on that ultrasonic. I definitely have been guilty of like turning it on, walking away, and coming back and like, oh, it needs to be closed, and then you turn it on. It needs to be finished, and then you open it up. You may even want to give it like a resting period between the time you turn it off and the time you open it up. But yeah, it's definitely a concern. It's a cesspool. It's disgusting. It's got all the day's grossness in it. And so we really want to be mindful of the aerosols. Like I said, we have the chemical aerosols that we have to contend with, not just infectious.
What about supplemental HVE like Isolite or Mr. Thirsty? Patients can't close on those, so no backflow, right?
They cannot close on that, and they are coming from your high volume evacuation. So it is a little bit different than your low volume evacuation. I did have those in a previous course, and I took them out because when I asked my ortho friends, they're like, I don't know if I would really use it, because I'm usually doing, anterior. I don't really do half mouth. But hey, man, if you like those, they work great. When I do get to the anterior aspect, though, I have had to use a second high volume evacuation for that real ballistic spray. So it does pull the water, gets the pooling, gets those tiny little droplets that fall real fast to the back of the throat. But anytime I have that ballistic, like my air powder procedures, my ultrasonic, and if you guys are doing the debonding, I did have to hold that second high volume evacuator in the anterior aspect.
So I asked you about plants in the operatory, but what about TV screens, other furniture, just anything in the operatory? Should they be covered,
So
wrapped?
yeah, right now they are saying take everything out, like take it all out. There should just be minimalistic. Like we are taking it down to bare bones. But I would say in the future, if we are, it becomes a recommendation that you can bring chairs back, and you can bring, things, TV screens. They're not, I mean, if they're like right here in front of the patient's face, I would be very concerned about that. And I'd also get your manufacturer's instructions for use for cleaning that down. Now, they do create monitors that can be wiped down and disinfected. The man and machine creates these keyboards that you can use that can be literally submerged and pulled out. So if this is something that you really appreciate and love about your office, that you have these items, there's solutions to those concerns. There really are. But for chairs, just also know that, I see a lot of my front office team. They'll come grab my, disinfectant wipes, and they'll carry them up front, and they'll wipe everything down. And the thing about that is, thank you. I love that you're helping me. However, they need to be trained on the proper PPE. They need to understand the first aid issues that go along with those very high level disinfectants. And also that disinfectant isn't always kind to your wood surfaces, or they'll leave a film on glass. So you may want to rethink about think about the products that you use on equipment that's not your clinical equipment.
So we are at the 1 hour mark. We do still have a lot more questions, so I'd like to try and get through a couple
Yeah,
more.
I'll try to keep my answers quick. We can do rapid fire.
Yes. Can you refresh us on what the waterline test was that you did?
I was using Pro Edge, but there's quite, you could contact your Henry Schein rep and they would give you some other recommendations as well. Mine is Pro Edge because it does have the in-office test, so I can do that. And they have a ton of, they hand hold me on my water lines, so I appreciate them.
Should each operatory be sectioned off if aerosol procedures are taking
That is
place?
recommended, yes. And it could even be something as like the one ortho webinar I watched with Jackie Dorst, she even said like shower curtains and shower curtain rods or poles where you can wipe down that clear plastic.
What's your thought of using hypochlorous acid and sprayer to disinfect clinic and reception areas?
You are the third person to ask me that in like 3 days. It's actually on my list this weekend to dive into that. I've not heard a lot about it. I know that there is a company out there that is sending me research. I personally am going to dive into that. But the people that I trust that are sending me their information, they have very high hopes for it, especially in regards to HPV, which a lot of our disinfectants are not adequate for HPV.
Do you recommend running the air and water syringe every morning if we use blue tabs and distilled water?
That is, yes, it's not just a recommended, it's a requirement. They tell you 2 minutes beginning of the day and also between patients. Because even though those tubes are the straws and the blue tabs, they're all working, it does not, if that water becomes stagnant, it's about flushing it out and keeping it moving all throughout the day. So that's why you flush.
All right, I had a really good question. I just lost it. Let's see. Do you recommend preset trays with already wrapped sterilized instruments to be in a closed cabinet?
Absolutely. Or if you used some of these organizational kits where they have the locked lids, because that's how you should be transporting your instruments from chair to sterilization is within these these containers with locked lids. It could even just be a Tupperware container. It doesn't have to be anything super fancy, but there are some companies out there that have these locked lids and you can kind of just stack them and then kind of grab them, open them up, and then wipe them down afterwards. But closed places are always best.
Since there are some studies that COVID can last in the air for hours, how do you recommend sterilizing the air since the next patient coming in will open their mouth?
I recommend worrying about using your high volume evacuation. Like it's not about sterilizing the air. That's a hard thing to control. For me, it's about controlling, do they have a face mask on when they walk through so that if they do cough or sneeze, it's in that face mask. As soon as they sit down, then we can remove the face mask. And then I have my high volume evacuation happening. I have my air purifiers or I have my HEPA filters. I don't particularly want to be spraying the air. One, those are droplets, they're going to fall really fast. Now the foggers are a different thing. Again, I'm not as educated on that right now. I will be this weekend, but I would be more concerned about eliminating it before it actually gets into the air as much as possible.
What is the safest way to clean or replace suction traps?
You need to be wearing your PPE. I personally wear my utility gloves. I take a rongeur and pull that trap out and then dispose of it and put a new one down in there. And then I wipe everything down, including my utility gloves.
Cool. Well, I still have a lot more questions, but we are about 10 minutes over, and I'm seeing a lot of COVID-specific questions. So I do want to put out there that Henry Schein has been putting on COVID-19 in dentistry webinars weekly. So if you go to the Henry Schein Dental YouTube page, you'll find all of our videos. Michelle is included in one of them. Lots talking about aerosol management, PPE, anything you can think of for COVID. It's all there. So with that, thank you very much, Michelle, for your presentation and answers. And thank you everyone for attending today's webinar and asking all of these questions. As a reminder, if you did elect to receive CE credit for today's webinar, it's required that you complete the survey upon exiting. As a thank you for attending, everyone will receive a link to view the recording of today's presentation in the coming week via email. On behalf of Henry Schein, thank you, Michelle, for a great webinar, and thanks again to all of you for attending. Everyone stay safe.